Good evening, everybody. This is UroChannel from Germany, and in Germany it's 8 o'clock right now, but I know in other parts of the world it's in the middle of the day. So you can see it's dark already. We are going to into fall here, and soon there will be snow and Christmas. And I'm really looking forward to the Christmas season because it's always very much fun to do some videos when it's dark, because you can't go outside, and then it's more cozy inside and doing some videos. Live streaming on UroChannel is a new thing. I've started live streaming 2 weeks ago. This is the third live stream we are holding, and the aim of live streaming is to give you some insights into UroChannel. What am I doing during the week? What are my experiences in my practice, because I'm working full-time as a urologist in my own practice, and then I'm doing YouTube, of course. And what are my latest uploads? What are the stories behind my latest uploads? How am I doing my creative process and come up with new ideas for videos. And of course, I'm going to go through some comments and one big topic. Today's topic is going to be PSA, the prostate-specific antigen and prostate cancer screening. We're going towards November, which is Movember, as many of you may remember, and it's the month dedicated to prostate cancer awareness. So I think it's a good point in time to start talking about PSA and what I do and how prostate cancer can be detected, and if this is a good thing or if PSA just is all a big lie and whatsoever. So last week I talked about memberships. I want to start with memberships today because only members can join the chat of this live stream. I did all the dial and the fine-tuning that only members can go online and chat with me. And I'm very glad that some of you are members, and I can see 14 are online right now. So welcome to this live stream if you just started to watch my channel, to watch this live stream. And there are memberships, so you can join them, and there's the cost is about €2 per month, and by joining the membership you can support my work here on YouTube. So what I wanted to talk about, last week was my shop. So I started a shop on UroChannel, and wait, what's going on here? YouTube not receiving. Studio. Wait. Okay, the stream status seems to be poor, but I'm continuing anyway. So if you see this and it's not working, please tell me so that I will have to stop the stream and start streaming again. But I will continue, and if something's missing, I will just start from scratch when the stream is working again. So I see there are only 10 of you joining this stream. Maybe it's not working, so give me a chat message if it's working, if it's not working. So my shop. So last week I was telling you that my garments, they were presented upside down, so you could only see the back of any apparel that I posted there, but some of them turned around. So you can see now the Rock Hard collection and parts of the Stone Age collection, and of course Above Average and the UroChannel collection. Speaking of Above Average, there's been questions about why above average and why did I choose that slogan. And the reason is that I have one video which is very successful on YouTube, which is about the size of a normal penis. I think it's called 6 inches not normal, something like that. And I got tons of comments on this video. Most comments were like this: oh, I'm above average. And the other guy says, I'm above average too. So pretty much everybody who's commented on this video was above average. And then I just hit me that maybe above average is the thing on UroChannel. So I started the above average membership, and this is the reason why it's above average. So it's kind of a joke, but I think it's harmless and you can laugh at it, and it's with a twinkle of an eye. So this is above average. Then I received this week, this was the message of the week for me. I received this from YouTube. And if you're wondering what this is the YouTube logo, and I can put it together. I will make a little video of it until next week, and I will post it, how I put the YouTube logo together. Thank you very much, YouTube. It was very much fun to receive this, made my week. So there was the videos that I did. There was one video about penis size I uploaded on Saturday, and this was how penis size related to the size or the volume of the nose. This was a very interesting research. Just a second. Oh, somebody's going to ask a question, but unfortunately, I'm not able to see any of your questions. Let's see. No. So if my assistant sees this, I would like to have the question on a piece of paper, please, so I can answer it. Back to my video on the nose size and penis size. So far, when I researched penis size and anthropometric measurements around the world, it appeared to me that nose size or correlating any other measurements with penis size didn't really lead to any solid data, but it appears that this has changed. And the reason why this is because we now have a handful of studies, it's 2 or 3 studies, which deal with the topic of nose size in correlation to penis size. When we are very young, so it's before we are born, we as boys get a lot of testosterone as a fetus. And this testosterone has a huge impact on our development and also onto the development of our penis, but obviously also other features which characterize us as men. So we have larger noses as women, for example. So it is fair to think that if we get a lot of testosterone and this has an influence on eventual penis size, it will also have an influence on eventual nose size. And we know that if we get a lot of testosterone very early, we can develop to our full genetic potential, which means that the penis can grow to its genetic determined size. There's some more testosterone surges that we have to go through, the largest one being during puberty. And if you don't hit those, you won't be able to get the full size of your penis as it could be due to your genetic potential. So don't think that testosterone alone determines whether you have a large penis or not. And this is one of the mistakes many make who watch these videos. You know, I have this video out there about finger correlation and penis size. It has to do with genetics. So just putting in, submitting the penis to a lot of testosterone won't make it that large. So you have to have the genetics. And if you don't have them, your penis is not going to grow very large. But both in combination will get large results. And the same seems to be true for nose size. So they measured the nose and they measured the volume of the nose in these men, and they came up with a correlation between nose size and penis size. And as I explained in my video, a correlation it's not a rule. So it's not that if you have a large nose, you will have a large penis. But if you take 1,000 measurements and you put them all in a graph, and you depict nose size and penis size as a dot in a system, you will get a scattered pattern of dots. But computers will enable you to calculate whether you could see a correlation, such as when penis size is huge, nose size will be large as well. So you get a curve or a line eventually, which will tell you about the correlation that's forming. And of course, we have some very strong correlations that we observe, and sometimes we have weak correlations, and it can be a median correlation or whatever, but you can get some kind of correlation, or you have correlation, no correlation at all. But these studies found that there was a correlation, even if it was not a very strong one, but it was a medium one. So that if you measure your nose and you measure your penis size, you might be on that line, and to say that a large nose maybe is followed also by a large penis, depending on the genetics, of course, and it's a correlation. So some of you wrote in your comments nasty things that was a lie. No, it's not a lie, it's a correlation. Only that you are not falling into this category doesn't mean that this is false. So you always have to look at a lot of data, and you have to calculate the correlation, and then you find these things. But it's not that you look at somebody who has a large nose and you know he has a large penis. Could be, it's possible, but it's not a law. So you can't really be sure with this. Plus, there was maybe a bias in these data, such as only Korean and Japanese men were being looked at. And there was one comment that I received during the last week telling me, okay, the Asians, they only have small penises. Yeah, it's a known fact that Asian men have smaller penises, somewhat. But I have also a video out there showing that also in Asian men, you can have 7-inch penises and larger. It's not a law that only just because you are Asian, you have a tiny penis. So also here we have a normal distribution, which means that we have most of the guys who are gathering around the median, the mean value. But there are also outliers. So also in Asian countries, you have men with exceptionally small penises and also exceptionally large penises, and penises at a size that may also be much above average in other countries where you would normally think that they have larger penises. So it's the same with the correlation, and it doesn't have anything to do with whether you're from Asia or not, and in relation to penis size. But even in Asia, if you correlate penis size with nose size, you have this, and only in Asia, as I said, we only have Asian study results. My problem with these studies was that depending on ethnicity, nose size may be different in other ethnicities. So if you would take a Caucasian, would nose size as a rule, like if we took percentage or so, be larger than in Asian people, but the form and the shape of the nose is something that's different also. So if you would correlate that, or if you could calculate that, if this would hold true also in other ethnicities, and this seems to be one of the points that has to be proven, and we need more data on this, and maybe a study in another culture, in another country, where we could look at this in another subset of men and see whether this will hold true also in other ethnicities. The next video I did was about a case report, a patient of mine, which I thought I would share with you because there were lots of very interesting results with this patient that I had. He was 62 years old and he had some mild erectile dysfunction, and we did some combination therapy on him. And maybe combination therapy is something where I would say, oh, I could be onto something here, because I'm combining now the P-shot, the PRP, platelet-rich plasma, with shock waves and EMTT, which is extracorporeal magnetotransduction therapy. I did videos on all of those. And these three therapies, they are rehabilitating the tissue. They are rejuvenating the tissue. So you take an old penis, so to speak, and turn it into a younger penis by subjecting the tissues to growth factors that are derived from the tissues itself, like in EMTT, ESWT, then also stem cells, which are released by these two modalities. We enhance neural response, and then we have growth factors from platelets, which are injected by the PRP. You know, PRP is platelet-rich plasma, which is taken from a blood sample. It's your own blood, only that it's processed blood. It's processed in a special centrifuge. I always take 60 milliliters of blood, and these 60 milliliters, they boil down to 4 milliliters of PRP, which is plasma and platelets. And these platelets and plasma are then injected into the penis, where the platelets then release their growth factors and lead to some tissue regeneration. And in this patient, we saw results after about 6 weeks. The first results appeared. And this guy, he was a fan of Brian Johnson, you know, the billionaire who was trying to get younger with each day. So he wanted also to get younger, or to rejuvenate his penis. And then he, in order to track that, he bought a sensor. This sensor is something that you put on your penis and you go to sleep with it, and the sensor sends data of your nighttime erections to your smartphone. So you get data on the number of erections, the duration of erections, the hardness score, and then it takes these data and correlates them with the age groups. So we have a database, we know in this and that age group there are so many nighttime erections of so on that duration, and this is what this program does. And so in the end you get a score, and this score tells you how old you are, or how old your penis is in relation to your chronological age. And this guy was 62, and he sent me a report then after 2 months telling that he was 26 in his penile age. I was very glad at this, and he was too. The thing is, I had other patients this year where I applied this combination therapy and it worked in a similar way. And this is why I thought I might publish this on YouTube. This is not a study. This is a case report, an observation that I have made. But so far, I would say I've never had a success in this scale from the therapies that I did when I applied them on their own. So P-shot on its own, ESWT on its own. I never had results like this. There were results, but not in a scale where I would say, well, this is a penis of a 26-year-old. Maybe I could turn a penis of a 62-year-old to a penis of a 56-year-old, something like that. But it was a large leap in function, which is very interesting. So I'm following down this path, and I will report more on YouTube when I get more results. And I'm also planning, maybe I'm doing some research incorporating the sensor, which name I'm not supposed to say, in case you're asking. Because as doctors in Europe, and especially doctors in Germany, we are not allowed to do any kind of advertising. So I'm not allowed to tell you any names of any product. I think the sensor is very good, but and it's fun to use too, but I'm not going to tell you what the name is. So you have to figure it out by yourself. Go to the video, click on the video and watch it until the end. And in the end, I'm telling you the name in a riddle. You have to solve that riddle. Many of you solved it already, but I didn't publish the comments because by doing this, it's more fun for the other ones to figure out what the name of this device is. Next video I'm uploading, it's tomorrow. I've already uploaded it, which is very much fun. And it's a new way of, new kind of video maybe, I would say. It's about brainwashing. So have fun with that video. It came about by chance. I didn't intend to make this kind of video, but I turned my process upside down. This time I made a thumbnail and title first because I had a great idea. It hit me in the middle of the night. So 4 o'clock at night, I woke up and I had this idea for a thumbnail in my mind. I just put it down on paper before I went to sleep again. And then I had this thumbnail and I thought, what kind of video are you doing to this thumbnail? And this is what I came up with. So I'm very excited to see whether it's going to be a success or if it's going to be a flop. We'll see. So memberships, I told you about this one. If you're not subscribed to UroChannel, please subscribe to UroChannel, hit the thumbs up and make this channel grow so that more people can get information about health-related topics. Because I'm a urologist, and the reason why I started UroChannel was to inform about urological health. I happen to be also a specialist in sexual health, sex cells, and I found out that the penis is something that sells extraordinarily good. And if you look at YouTube, no matter what niche people are in, it seems to be that everybody's uploading something about the penis, even remote fields. Like, I haven't seen it, but I really could imagine that financial videos would post something on the penis, or I've seen lots of crazy stuff already. But today's topic is PSA. PSA is the prostate-specific antigen, and PSA is a marker that we use to come close to a diagnosis of prostate cancer. And as I told you in the beginning, prostate cancer month is coming up in November, which you also could see it's Movember. People have the mustache. I'm not quite sure why this is, but I think it's because, at least that's my explanation, it's because the seminal vesicles, if you look at them with the ultrasound, they look like a mustache. Maybe this is why it's Movember. If you're from the Movember movement, leave a comment and enlighten me if this is true. I'm not quite sure about that. However, PSA is not a new marker. We have had PSA for a long time, and in the beginning of the 90s, it was introduced in the US for prostate cancer screening. And screening means you have a man, he's feeling totally healthy, and you want to find out if he's sick with prostate cancer, although he doesn't feel anything. And then you take a blood sample and you put it in a machine and look at his prostate-specific antigen PSA level. So you come up with a value and you correlate this value to the risk of having prostate cancer. This is basically what screening is. So we have a test, a blood test, which is easy to do, which can be spread all around the country, and then you could diagnose prostate cancer large scale. So this kind of screening has been criticized very much, and there's this endless debate on whether prostate cancer screening is something that you should do or you shouldn't do. The current status of prostate cancer detection is more like an opportunistic detection, which means we have a guy and he comes into the office and he wants to know whether he's sick or not. And I have plenty of these men. So they have no symptoms. And you have to know that prostate cancer in the beginning stages and for a very long time doesn't cause any symptoms. So you wouldn't know whether you had prostate cancer or not. Sometimes if you have symptoms, they are very close to benign prostatic enlargement. You have the urgency, the weak stream, all of this stuff, the nocturia where you have to go to the bathroom all of the time. Also, this could be symptoms of prostate cancer, but most men, they don't feel anything. So if they walk into the office and just want to have proof that they're healthy, then you're running into a situation of opportunistic screening. So you want to make sure that this man first of all understands what the implication of screening or prostate cancer detection are. And this is very difficult to understand. And I remember when I was a resident, it took me years to have an idea about PSA and how PSA related to prostate cancer and what it really meant. This makes it very difficult for people who are not working with PSA to understand what PSA is and how to use PSA, because in the right hands, and if you're experienced, it's an excellent marker. But you can do a lot of crazy stuff with PSA, and I don't think it's a good idea that everybody should handle PSA and that everybody should take PSA, because it requires some more work around this and some background knowledge and some experience. So as I said, first of all, you have to know about prostate cancer, that this is one of the most commonest cancer in the world, or in the Western world, in men. And you have a very high likelihood that one day one doctor will tell you that you have prostate cancer. Problem is, only a small subset of men die from prostate cancer. So we don't want to cure anybody from something they don't need cure for, right? So if you have a prostate cancer and it's not doing anything to you, so what? You can just forget about it and live on. But we must not forget that there are also many men dying of prostate cancer. And this is a problem. So to say that prostate cancer is totally harmless, it can't be more wrong. So there are dangerous prostate cancers. Most prostate cancers will raise their ugly faces at the end of their 60s. So it's the risky years start with 50. It really takes off after 60, and around 70, most men will get their diagnosis of prostate cancer. We have autopsy studies, and these are quite old, but I think they hold pretty much true. These autopsy studies are done in cadavers of men who have died of totally unrelated causes of all age groups. And they have done a biopsy on the prostates of these men who came in after they have died, just to look how healthy the prostate was. And it turned out that the first sign of prostate cancer cells can be seen quite early in men. So at the end of the 20s, you could find prostate cancer cells in some men. And this number increases quite dramatically. So when you're in your 70s, 60% of the men have prostate cancer cells. So if you just go on and on, like if you would be 110 years, I would guess 100% of men would have prostate cancer cells. We don't know why they appear, how they appear, and when they appear. But we know that lots of these men never would have gotten any problems with any prostate cancer, which tells us that there are prostate cancers which we call clinically not unimportant, which we rather would not diagnose, which we rather would leave alone because they would never cause any harm. And in this scenario, we now have a marker which is called PSA. So if you take PSA, you would be able to diagnose many more of these cancers, which we never want to diagnose. And this is one of the problems in a man who's coming in and telling you that he wants a screening. Because there is a risk that he might end up with a prostate cancer diagnosis for a prostate cancer that never should have been diagnosed. There is also a chance involved in this, because sometimes it could be a good idea to take a PSA because you could catch a very nasty prostate cancer early and have a real chance to be cured. These are the real benefits of testing for prostate cancer. Plus, we must not forget that now I'm talking about death, but there's also such a thing like disease burden. We call this morbidity, because prostate cancer is only asymptomatic until a certain point in time, and as any cancer, it will spread in the body. It spreads in the lymphatic system first, and then it also spreads very easily into the bone. So we don't have organ metastases. Yeah, you can kind of see them sometimes, but most of them are in the bone. And you don't want bone metastases because they cause a lot of trouble. They cause instability and the bones can break. I had a patient in my early years. He wanted to eat a bit of chocolate, but just breaking the chocolate from the bar caused his his arm to break because of metastasis. And you could also end up in a wheelchair because you could be paralyzed if it breaks in the spine. So these are the problems, and we don't want these. So preventing morbidity and preventing complications from a prostate cancer is also a very important goal in diagnosing and also treating stuff, because you don't want to end up in a wheelchair, right? And these are the things that you have to keep in mind when you talk to these patients. The other thing is, up to now I was only talking about, well, no risk for prostate cancer, or we maybe find some prostate cancer, but there's also another category which is very important and which makes it very hard, which is the in-between category. Sometimes you cannot end up with a result telling you, well, we think there is prostate cancer, but you don't find anything, which is a big problem, because then you go on testing and there are test intervals and people really feel like a patient, and maybe they don't have prostate cancer, but they feel sick because they feel like a patient. Or you find prostate cancer and you have the notion that, okay, maybe we shouldn't have found this one. It's a very tiny one and it looks very nice on microscopy. And then you tell the patient, okay, maybe we could just observe it. We take the PSA and we observe it with the MRI. And then once in a while we take a biopsy to look at it, what it's doing. And when it's the right time, we just take it out. This is also a big burden for the patient, because now we have a patient that has to go to the doctor very often, and then you have all the fear involved. What is happening? Is it growing? And most patients, they just can't stand it. After 2 years, they say, I can't stand it anymore. You just have to take that one out. And you take it out, and you end up with an overdiagnosis, that's the name for it, and overtreatment, because you have diagnosed something that you never should have diagnosed and treated something that you never should have treated. These are the risks and the problems involved with prostate cancer screening. So then you have factors which could blur the PSA. And above all, this is the volume of your prostate. So when you get over 40, most men will receive a growth of their prostate. So it's not a swelling. We'll talk about this in another video. Prostate doesn't get swollen, it starts to grow. This is real cell multiplication, and the organ will start to grow. So it starts as a small chestnut, like this size. But the largest prostate that I have in my collection here, my patients, is this size. It doesn't fit on my screen anymore. And the larger the prostate gets, the higher the PSA level will be. I forgot to tell you about what PSA is meant for. PSA is for fertility. So it's an enzyme produced in the prostate, which has some duties for fertilization in eggs. So it's for sperm to function. This is why we have this. So it's a natural enzyme we have in all prostates, but it can be elevated with prostate cancer. So when the prostate starts to grow, there will be more PSA. And you have to take this into account. And the only way to, in my mind, the only way to take this into account is by doing an ultrasound of the prostate to really measure how large that thing is. And this is what I'm doing with all of my patients when they come in for prostate cancer screening, because I want to correlate my PSA to the size of the prostate. And the best way to do this is by transrectal ultrasound. This is a probe that's the size of my finger, which is inserted into the rectum, and then you can measure in cubic centimeters how large the prostate is, and you have a superb view onto the organ. And correlating this will get you some more insights into the prostate value that you're getting. And another thing that I'm doing is something that's called the free PSA, which is a fraction of PSA, which is not linked to any protein in the blood, but therefore it's called free PSA. And this ratio will also tell you something whether the level of the PSA is more related to a large prostate or not. So normally a very large prostate with a high PSA will have a ratio that's above like 25%, the free to total PSA ratio. So this will tell me, okay, most probably this is just benign prostatic enlargement which is causing this. Then you could also have PSA density. You can correlate PSA to prostate size in this way, to how dense this distributed in the prostate. Also, this will tell you something. Then there's PSA dynamics, to have to watch PSA over a certain time. So tonight I called a patient. He has a PSA of 3.6. This is for the 64-year-old guy. Okay, I would say, yeah, there's a slight suspicion, but his prostate is 62 cubic centimeters, so I'm not that worried. His free total PSA, it's 14%, so I would say, I want to get some feel for this. So I will call him in half a year and just have a look at the dynamics. If I am suspecting anything like prostate cancer, I will then go for an MRI of the prostate. There are special MRIs. It's not the normal MRI, but it's multi-parametric. That's what it's called, multi-parametric MRI, which is a special software which is just to put onto the slides, and then they will look at those and see whether there is a chance for a prostate cancer. These MRIs are very accurate. They're not a diagnosis. The only way you can diagnose prostate cancer is by doing a biopsy. But before performing a biopsy, I would usually then call for an MRI to make sure that I have a reason to put a needle into this patient. And sometimes I don't, because it's not suspicious enough. And then I would just leave it and I would have a look at it, because you don't want to be too aggressive. Sometimes I am. And this sometimes has to do with my finger. And I know this is not very popular, and there's been a lot of talk about whether we should do the digital rectal examination or not, because it's not very reliable. I know that, but since when is examining a patient out of fashion? I mean, this is what we do as doctors. We examine our patients, and this is what we must do. And if you're a colleague, I really urge you to examine your patients. It's amazing what you can find sometimes, and what trouble you can spare yourself if you've examined your patient. And I mean, we know that if feel something in the prostate and the PSA is high, I double my chances to find a relevant prostate cancer. So there is a correlation to what I can feel with my finger or not. The reason why sometimes you don't feel anything is because only 90% are palpable of the tumors. They're not, all of them are located in a spot where they are accessible for the finger. Then there is also size of the finger. My finger is not very large, not very long. So sometimes I would need a finger like this to reach the prostate. And it has to do with the size of the guy I'm looking at. If somebody is obese, my finger very often doesn't reach the prostate or just a part of the prostate. And then I would not feel very much. But I mean, so what? Then I don't feel anything. I do the ultrasound, I do the PSA. But sometimes it's important to have these results with the finger. And I remember a patient, he had a PSA of 2, I think 2 point something. And he wasn't my core patient, so he came to me for erectile issues. And he was seen by another urologist for his prostate. But I made it a rule to have a picture of my patient. So I want to have a reading of my finger of the prostate before I move on with any patient, because I don't want to overlook anything. So I palpated his prostate, and I thought, well, this is very suspicious. He might have a cancer. So I told him, go to your urologist whom you're seeing on a regular basis and ask him to palpate your prostate. I think I feel something there. And he did, but the urologist obviously didn't palpate anything. So you can see it's only 30%. And it's also dependent on who's doing it. Some feel something and others don't. And then time went by. I think a year or more than a year. Then he started to get pain in his lower abdomen and in his small pelvis. And the PSA was still not very high. And he went to his family physician, general practitioner, and she was laughing at me because she said, such a dumb urologist. There's no chance there's a prostate cancer at a PSA level this low. But you have to know that PSA is not very reliable when it comes to a special subset of prostate tumors. And these are really nasty suckers. They grow very fast, they're very aggressive, and they don't make any PSA. Luckily, these are rare. I'm always afraid to miss one of those, but you don't see them very often. But this one, this guy, he had one of those. So at the point when his PSA was 2.7 or 3.0, something like that, not very high, he had metastasis, and he had a very spread tumor, and it was like very aggressive and lots of trouble. So one could have diagnosed this a year earlier by palpation, but I mean, it was palpated, but I thought I would palpate something there. So I'm not saying that I'm doing everything right, so I'm only human. I do what I can, and I do it to be as precise as possible, but I won't say I don't have a chance to miss anything, so I'm just human. I try not to miss anything, but maybe that's I'm a bit paranoid about this thing because I don't want to miss anything. But this is important. I think it's important to palpate a prostate. Another example, I had a patient recently, and this is a big problem. So when do you want to go on with PSA? I was talking to you, when should I start? Well, risk age begins at 50, but you may want to think about it when you get 40, because if you have somebody in your some of your relatives, a father, a brother who's been sick with prostate cancer, you might want to think about early detection. And then you might want to have a PSA taken at the age of 40, maybe 45. where you can be pretty sure that prostate is not very large, so you get a clean reading without prostatic enlargement so much, and then you have something to start from, and you can go with lighthearted to the examination because, you know, they wouldn't find anything anyway. So in this age group, I would say most of them have a PSA below 1. But having this baseline reading, you would then, in the years to come and in the decades to come, have the chance to see what happens to your PSA. Because if you start at 60, you don't know where you're coming from. And it's much easier to know where you're coming from, to kind of look into the glass sphere and see where you're going to, than starting late. And it's not recommended that you start screening above the age of 70 if you're asymptomatic, because prostate cancer, as a rule, grows very slowly, which means that you have at least 10 to 15 years until you, from diagnosis, if you're asymptomatic, until you feel something from your cancer disease. And if you look at your cohort, and you can figure out how old you're going to be when you die, and there's data on this and statistical data on the internet. You just type in the date of birth, and then they say, well, statistically you're gonna be, I don't know, 76, 78 years old. You really have to take this one into consideration. So if somebody who's 75 maybe has had a stroke or a heart attack and he's not too healthy, does he really live on to be 85 or 90? Because only after 10 to 15 years you're going to harvest what you invested into. So you don't want to have a prostate cancer operation because you always pay with health while doing this, and then you die 2 years later. I wouldn't recommend that. So it's in a way it's a bet. You bet you get 90, okay, then you get your operation at the age of 70, 72, 73. If you're very sick, well, congratulations, you're probably not going to have any chance that this cancer is going to cause you any harm. And this is what's one of the things that you have to talk to your doctor about, and also about the parents. I had a colleague, he once told me, any guy above 70, he told me I will operate on them if they come with their parents. No, because genetics play a role. So if your parents were very old when they died, and they were, and they were healthy, then you have a chance to be very old as well. So that might be something worth doing. So we got some questions here. Okay, 3 persons said hello, so hello back. Yeah, if you have some suggestions for live stream, for topics, just post them in the comments and I will look at them. And then if they're interesting, so I will talk about them in one of my next live streams. But back to my patient. So this happened this year. A patient comes in and never been tested for prostate cancer. And he feels healthy and he looks fine. And looks younger than he is, and he's 75. And he asks for prostate cancer screening. So what do? And this is a big problem, because we have somebody who's never been taken a PSA. I'm so afraid you can't believe it, to diagnose a prostate cancer in this guy. And there he is, and he wants a screening. So I decided I'm not doing PSA. Because he doesn't have any symptoms. And I said to him, well, listen, if we take PSA and it's something that we don't really know, maybe we go down the wrong path. So what I want to do is I just take a look at the prostate with my finger. So I do a palpation of the prostate. And if this is okay, then we don't do anything. We just leave it.
Question.
Okay, question. How to shrink prostate and improve urination flow by changing lifestyle. Okay, I'm going to answer about this one in a second. I just finished my talk about this patient. So this guy, he went along with this, and then I palpated his prostate and bingo. So obviously he had a cancer, so I could really feel this. And then I had to go ahead and take PSA, and then it was high, and it turned out that he was having advanced disease and he was metastatic. Should I leave this? And I don't think so. So this is one of the situations where I would say, like, okay, we have to prevent damage from the disease in this patient. We don't want him to have any fractures. We don't want him to have any neurological side effects of his disease. So we went ahead and did treatment. But hadn't I palpated anything in this prostate, I would have just left it alone. So this is one of the dilemmas one can come into as a doctor, and one of the cases where you have to decide for something. Do I go for it? Don't I go for it? Because would I have left it alone and not gone for palpation, I think he would have had a chance to get some real side effects of his disease. So I think it was for the better to make this diagnosis. So as you can see, it's not very easy, and there are lots of questions involved in doing PSA testing, prostate cancer screening. The finger alone for assessing prostate size is not reliable. I wouldn't recommend it, and I don't trust my own finger, because the prostate has different sizes and different shapes, and if you insert the finger in the rectum, sometimes you can't feel anything. It feels very small, but then it bulges more inside the body. And if you measure it, you say, wow, this one is very large. And sometimes you think, wow, this is enlarged. And then you stick in your ultrasound and you find out, no, it's not enlarged at all. So my finger is wrong very often when it comes to prostate size. And I don't rely on that. And I think in combining all of these methods and experience and readings over time, PSA can be a very, very, very valuable tool to screen and assess for prostate cancer. And if these persons want to be screened and they say, yes, I want to be screened. And the thing, if you're watching this and you're 40 years old, you're 50 years old, you've never been screened, I think it's the golden opportunity to sit down and think about whether you want to be screened. There are good reasons to say, yes, I want to, but there are also reasons to say, no, I don't want to know about this. I want to leave it alone. And one of those reasons could be, and I have these patients, if there's something to be found, what would you do then? And I have some patients who tell me, yeah, I don't want to go for biopsy. And if it's very clear for you today that you never would undergo a biopsy for prostate cancer, then you have a good reason to say no to prostate cancer screening, because this might be the result of a screening test. As I told you earlier today, the only way to diagnose prostate cancer is by biopsy. So maybe I'm talking about biopsies another time, because we are moving forward here. So I want to have a look at this. How to shrink prostate and improve urination flow by changing lifestyle and pelvic exercise. This is a different topic, so I want to go into detail for this one, for benign prostatic enlargement. I covered this a little bit today, telling you that the prostate starts to grow when you pass 40. And this is real cell growth. It's not a shrinkage. So diet will not shrink your prostate, I'm afraid. But diet can help to prevent growth. And the earlier you start with a healthy diet, the better it is. And there are some risk factors. There are some studies that tell us that exercise at a young age, starting at a young age, is maybe protective from benign prostatic enlargement. So there were some relations and correlations between movement patterns and physical activity and prostate size. What I think is important to note is that if you want to engage in any kind of physical exercise, you have to have a physical examination by a doctor who can have a look at your heart and just tell you, well, you're fit for physical exercise. Do that first before you start running right now after our session. It's a moderate to vigorous exercise that seems to have the best benefits. But if you're doing exercise, I recommend all kinds of exercise. So it's not just going for a fast run. I would also recommend you that you train yourself and you train your body in all different ways. So it's you go for long runs at a very slow pace. Then you also want to do intervals. Then you want to do some very strenuous exercise. You want to do weightlifting. You want to do flexibility exercises. And maybe you want to do something every day. You don't have to do the same thing every day, but you have to do a little bit every day, and it really rounds up the whole picture. So I would really recommend exercise. And exercise is a very important tool to fight obesity. Problem is, if you're not trained, you are not very likely to burn that many calories while doing exercise. It's only if you're trained, then you really start to burn calories, because if you're not trained, you're exhausted when the real fun part starts. So then you don't get into the range where you really can profit of physical exercise. But if you do, for example, you do something at a very slow pace and you do it for a long time, most of the time you have no time to eat, so this also prevents you from eating. I always see this when I'm going on a round of golf. I don't eat. Some other people, they eat. I don't. And 3 weeks ago, I went on a Saturday when it was still dark, because I like to walk fast, and I hate it when there's so many people in front of me and they move very slow. So I wanted to get it over with. So I played the 18 holes in 2 hours and 40 minutes. And I don't use any electric energy for this. So I walk and I have a trolley and that I push. And it's very much up and down here in this area. And when I was done, I thought, well, okay, I'm doing another one. So I went 9 holes, and then I thought, well, it's a nice weather. So I went with some other people. Now I went slowly, but I ended up playing 50 holes, which took me about 12 hours or something. I started at 6:30, and I was, quarter after past 5, I was ready. No, it wasn't 12 hours, but it was a long time. And I didn't eat anything. I just drank because I didn't have time. I had to play golf. And this is one of these days when you really feel, well, if you do something all of the time, you don't have time to eat. So that was the point. What to eat? I always recommend a Mediterranean diet, and the original Mediterranean diet, which is mostly comprised of vegetables and nuts, legumes, olive oil. There's lots of olive oil in this original Mediterranean diet. The original has been recorded by Ancel Keys in the 50s. That was his famous 7-country study. So he was an American researcher. He went to different countries in the world because he was interested to know more about whether people could live longer by eating other stuff. So he was the one who introduced cholesterol eventually, and this is why we all are looking at cholesterol. That was because of Ancel Keys in the 50s and the 7-country study. And the people who lived in Greece, they had the diet that would obviously grant them the longest life expectancy. So this Mediterranean diet, which is comprised of very little meat, as a matter of fact, and little fish, and it was also a calorie-reduced diet that yielded the most effects in terms of longevity. And we know that obesity is a risk factor for prostate growth, and obviously also overeating. And this original Mediterranean diet was calorie deprived because these were poor people. They didn't have money to eat more fish and to buy more meat. So they would have to eat what was there. And if you look at the old protocols, they would have the original writing on it, "I'm hungry." That's what they put on the protocols on the side of the protocol, because they didn't have enough to eat. But we know from animal studies, and animal studies can't really be transferred to humans, and therefore take it easy with these results on humans. But we know from animal studies that a diet low in calories and a little bit lower than you probably would need contributes to longevity. So mice who are fed with a low-calorie diet live longer than other mice that you feed with a high-calorie diet that get fat. And it's the same with the prostate. So if you overeat, if you're obese, if you eat too much, if you eat too many refined foods, if you eat too much fat that's saturated and all these refined stuff, then you maybe have a risk to get a larger prostate. These are correlations, and in these correlations, I told you about correlations in the beginning. So this is what you can do in terms of diet and workout and pelvic exercise. Very interesting. I made some pictures the last days about prostate size and symptom score. Today I had a prostate which was so great, this picture, because it's a huge prostate. And if you look at it, I have a very nice picture on my ultrasound. I will show it to you. The middle lobe is just bulging into the inner side of the bladder. And I saw this prostate and I said, well, this is definitely doing a lot of trouble in this man. But he said, no, I'm doing fine. And he could empty his bladder. And a couple of days ago, I had a patient who had a prostate that was slightly elevated, looked perfectly okay. And then he had very, very much trouble with his prostate, or with lower urinary tract symptoms. So the prostate itself, the size of the prostate, doesn't tell you whether the guy has problems. So the prostate is attached to the other structures around this, and which is the pelvic floor, of course. And the pelvic floor can be overactive. So what you can do in terms of exercise is not making your prostate smaller, but it can get relief from symptoms that might be connected to the pelvic floor, maybe because of enlarged prostate. We don't have enough data to know, but we know that men with larger prostates tend to have more LUTS, lower urinary tract symptoms. I don't recommend Kegel exercises in these men, because Kegel exercises are strengthening exercises. I think that most men with this kind of problem would rather have an overactive pelvic floor. And this means that the muscles are too tight. And this also means that if you train a muscle that's too tight, it gets even tighter. You don't want that. So you want to relax this muscle. So what you want to do is relaxing exercises and making muscles functional again, so that they can really stretch and contract at max, so that you not have a muscle that's contracting like this, but that you have a muscle that's can be stretched like this, and then it contracts to this. So this is what you can do. So there's some videos on this on the internet. I was kind of planning to do a course about this, an online course, but not this year, maybe next year. So yes, prostate size, PSA, ED. Is there a correlation, or is there some kind of connection? I was talking about prostate size and PSA, so if you just switch to UroChannel now, the live stream will be online right after I'm finished, so you can just have a look at it once again, because I'm explaining in detail how prostate size and PSA correlate. ED Yeah, there's a correlation between lower urinary tract symptoms, prostate size, and erectile dysfunction. We don't really know why, but this is why I'm always asking my ED patients when they come in for ED whether they have lower urinary tract symptoms. And I would also treat these if I found them, because they might they might relieve ED. So this is one of the things. Hard flaccid syndrome. I have to devote another live stream on hard flaccid syndrome. Maybe I can say so much. Professor Goldstein has agreed to appear on this live stream sometime in the future, and I definitely will talk to him about hard flaccid syndrome. So I don't see any correlation or connection to the prostate or prostate cancer or PSA and hard flaccid syndrome. But if you watch UroChannel, just switch to my live stream on Fridays, and I will announce it when he's online so that you can see his answer about hard flaccid syndrome. For the time being, I have some videos about hard flaccid syndrome with Professor Goldstein from June, and I made an interview with him about it, and there are 3 parts of it. So if you just scroll down to June, it's I think one of these is even named hard flaccid syndrome. Just have a look at it. Yeah, it is. It's called jelking, pumping, masturbating hard flaccid syndrome. So this is part 1 of 3, and there are all in all there are 3 parts. So I just want to have a look at the comments, maybe that which are coming in. Oh yes, thank you, Alex R50. That's very nice of you. It's unfortunate that nearly all urologists are just treating the symptoms with Viagra and similar medications. That's why you are like a demigod to me, Dr. Buntrock. Thanks. A treatment consisting of several methods. So what's the correct way to measure penis size? Okay, it's not about the prostate. Let's see if we have some more prostate questions. No. Not at the moment. Okay, thank you very much for joining this session. As I said, it will be online right after I close it. And next week there will be another session. And I'm very much looking forward to meeting you there. So wherever you are in this world, good day, good night, and see you then. Bye-bye.